Most people that I talk to, and this is 20 years in this business because I've really only ever had one job, and that's been working with families that are struggling with addiction in one form or another. And in a larger context, behavioral health. So when I say behavioral health, what I mean is alcoholism, addiction, eating disorders, and mental illness. But I think when most people talk about this issue, they're mostly focused on alcoholism and addiction. So we would call that substance use disorder. So in the newest context, whether you're talking about alcoholism, we're smoking pot, we're drinking, we would call that SUD, substance use disorder. So I think when most people interface with the system, it's when there's a crisis. So something terrible has happened. Someone fell asleep in the soup at dinner. There was a scene at Thanksgiving. There was an arrest. There was a DWI. And then all of a sudden there's this immediate need brought on by the crisis to fix it. In popular culture today, the way we understand fixing alcoholism or addiction is we send people to treatment. That seems to be the easy, immediate solution. So everyone calls and says, my name's so-and-so, this is the emergency, this is what just happened, and we need to get my son to treatment. I'm like, okay, I understand that that's what you want to have happen, that you think that that's the appropriate solution for the problem that you have. So from where I sit, and my understanding of the continuum of care, and when I say the continuum of care, what I mean is how we get well, how we proceed towards remission from this illness. So when you call me, I hear that you're struggling and you're in crisis and you want to get this fixed immediately and you want to get your son to treatment. You think, if I do this, if I move my son from this hospital to this treatment center, he will effectively get well. What I know is that if you do that, he has a 25% chance of recovering, of effectively attaining remission, of, we'll call it, staying sober for a year post-discharge, which is an easy metric for folks to understand. So that's really when they think, when people say they want me to fix their son, what they mean is, I want my son to grow up, I want him to be happy, I want him to be healthy, I want him to get married, I want him to have grandkids that I can play with, I want him to have a high quality life. So the reality is that there's X amount of money, right? There's always a finite amount of money, and there's an amount of time it takes to recover. So if we send someone to treatment and I send you away for 30 days, like I said, you have a 25% chance of staying well a year post-discharge. What I want is I want your son to get well right away. I don't want him to have to go through this again. I don't want the family to have to go through this again. We're going to get your son assessed, detoxed, and stabilized. That's the first thing. And really, that's all that happens in primary inpatient residential treatment. So people think that treatment's the way to go, that if we send someone there that they're going to get fixed. All that's really going to happen is they're going to get assessed, detoxed, and stabilized. The real magic for recovery, and this is the part that's not out there, that popular culture doesn't understand, that the healthcare system to a large extent doesn't understand. And when I say they don't understand, what I mean is it's not codified and they don't pay for it. So when you call up your insurance and you say, I want these kinds of services, they'll say, this is what we provide. So you utilize the services that they're willing to pay for. And then we need to look a year out, because really what we know, what the science tells us, is that it takes 12 months for all of the levels in the brain to reset, to produce their own serotonin, to chemically be at the levels they were before we started abusing chemicals. So if it takes a whole year for the brain to reset, we got to give it time enough and the body time enough to recover. The problem is that folks will go to detox, they'll get out 48, 72 hours later, and they say they feel much better. They do feel much better, but their chances of long-term abstinence, of being in recovery, are very, very slim. I want to get my son into treatment. I need to have it happen right away because this is a crisis. And I say, I hear what you're saying and I hear what you want. I'm going to tell you what you need. So if I'm writing the world's greatest continuing care plan, we're going to get folks assessed, detoxed, and stabilized at primary residential treatment. And then we're going to move on from there, and we're going to case manage them for a year post-discharge, and we're going to get them into a level of care where they can get their needs met for most of that time. When we're talking about sober living, the biggest challenge is that it's not codified in the payment system. So the Center for Medicaid and Medicare Services puts together most of the codes today. They write the codes for what the healthcare system will pay for, so it moves over to the private side. So if you have, it doesn't matter, whatever kind of insurance that you have, the card in your wallet, you'll say, what can I get for my son? And they'll say, you can get this, this, and this. Today, there isn't a code for sober living, right? That level of care isn't paid for. 20 years ago, we used to have halfway houses, and that was a big thing probably for the 30 years that preceded that, and a lot of times that was paid for, that was codified. And there was a billable code for halfway housing because it was a clinical level of care. as managed care moved forward and we begin to try and manage care, basically meaning that we're trying to contain costs. Part of the ways that we contain costs is that we limited lengths of stay, and we stopped paying for things that didn't have proven outcomes. So a lot of times if it wasn't a clinical level of care, they wouldn't reimburse for it. Sober living fits that niche exactly. The problem, however, here is that sober living is the most efficacious tool that we have in the continuum of care today. And the heartbreaker is that the healthcare system hasn't caught up yet to find a way to pay for it. If somebody comes to me and says, we have this budget, we have X amount of dollars to spend to get our son sober, and we're hopefully going to utilize some of the things that are covered under their insurance plan, but if they either don't have insurance or they need to private pay, primary inpatient residential care is expensive. Let's just say it costs $30,000 for a 1-month inpatient residential stay for chemical dependency as a baseline. So that means that parents are asked to write a check if they're doing it out of network or private pay for $30,000. That's a lot of money. I went out and bought a car today, and the guy who sold you the car said there's a 1 in 4 chance on day 31 that this car will start, but it's going to cost you $30,000 today. I mean, when we think about it that way, that's not how we buy cars. I don't think anybody would buy a $30,000 car that had a 1 in 4 chance of starting a month from now. But effectively, when we purchase residential treatment, that's what you get. So what we want to do is we want to take the amount of money we have and we want to spend it in the most efficacious way over the longest period of time to produce the best results. The father comes to me with X amount of money. He needs to private pay for his son, and if the budget's $30,000, he could say, I need to go to this treatment center. I heard they have great things happening there, that people get well there. I'm going to say that that's true, but I don't want to spend your entire budget on that. I think it's important that we can use a part of the money to get your son detox, assessed, and stabilized. So we'll do that at the local hospital for 3 to 5 days. And then either when the benefit runs out or if we're private paying, it's going to cost us, let's say, $5,000. We're going to take the rest of that money, we're going to spread it out across the rest of that year. We're going to try and buy him the longest period of time we can for his body and his mind to recover. So if I'm spending money inside of the system today, I'm going to spend my money on sober living. Because as I said before, out of all the tools available to me in the healthcare continuum today, hands down, sober living is the most cost-effective, efficacious tool that I have, that I can put in use, that absolutely, positively generates the best long-term outcomes. There's no doubt about that from the inside looking out. The really key piece here is about moving them back into community, about reintegrating them to life, because there's so much stigma and shame associated with having this particular illness. And there's so much stigma culturally that comes with recovering from this illness that overcoming that is a process. It doesn't happen in 10 days. It doesn't happen in 28 days. And the more tools you can give individuals to repatriate, to join a community, to meet other people that are doing the same things they are, to give them the opportunity to recover amidst fellowship and support over the longest period of time, that's the single most important factor to generate great long-term outcomes.